Now it's
So
Rob.
we're really glad we're seeing a balance here across the panel a little bit in terms of maybe outlooks. It's a really interesting period. There are a lot of questions and uncertainties. I think the foundation from which we find ourselves coming to the equation, and I think the spirit with which policy is being set is that we can't continue to operate in the status quo. And so, I tend to buy into the notion that I think a lot in Washington have been using as well, which is the notion of a crisis is a terrible thing to waste. So this is an opportunity to do some difficult things that haven't been easy for us to do, and it starts with change that isn't always comfortable. So, all right, so there's a deep breath around that, and then what have we been doing to try to understand it? We've been talking to the major constituents in all of this. We've been talking to the physicians. We've been talking to the health plans, the large providers, the pharma companies. And at the bottom, at the end of the day, all of them are very anxious to understand how they can get better value out of the system. And value comes with enabling things that ultimately get to the wellness of our patients and individuals. In terms of the total cost that this health that we're going to concur as a society, it's hard to. We do recognize that the cost is high now, and it's been increasing. And I think it's the rate of increase that's most staggering. The cost of increase in healthcare is 2.5 times the pace of increase, and this is over the last decade on an annual basis. The rate of increase is 2.5 times the rate of increase in other countries. And so we really want to see a movement in the direction that starts to stabilize some of that. Since we're a country that is a wealthy country, that is a one that's going to expect, and it's a compassionate country, we're going to expect to provide care. So I don't expect it'll go down. I think we're going to go into an environment where there's opportunities to make it much more productive. And some of the steps around IT are going to form a foundation to enable an understanding that allows us to drive the kind of productivity improvements that I think we've been able to do by using IT in other industries.
Just to add a little sidebar, most of the package is going towards physician incentives. Some $17 billion is in that pipeline, if you will, with the idea at the end of the day, are we providing better care for patients at the end of the day? Notwithstanding Tracy and Glenn's relative gloom and doom, this side of the panel.
Is that the right?
Well, you used the term right. We believe, quite frankly, at the end of the day, it's that patient. And to think that all of a sudden there's this, these pennies from heaven that are going to start flowing down, they're already there. They started about 63 days ago, 66 days ago, with the e-prescribing incentive. So that's already in place. And this is a building momentum. First, we offer that carrot, right? We offer this opportunity for docs to get this incentive. And then over time, we begin to change the carrot into that proverbial stick. Notwithstanding what you feel about disincentives, if we get docs there in the first place, we think that's the most important thing. If we can get them used to the idea of using a smart technology, using their cell phone to order prescription medications, to actually start looking at some of the free software that's out there for e-prescribing and kind of let physicians stick their little toe into the water to determine that it's not as bad as it might otherwise seem. That we've got to begin to transition physicians. At the same time, we have to start changing expectation levels, not only of patients but of systems. So we've got to change the culture within health plans, for example, to shift the dynamics so they begin to recognize, wow, here are two physicians that provide the same basic service. Who's providing better care at lower costs? Because that's what it's about. We are on a value-driven train, that, unless we start getting, as someone indicated a little while ago, if we're not getting out of our investment what we're putting into it, then there's something wrong. And right now we're spending more money for poor care. What we've been able to determine over the past 6 or 7 years is those systems that are providing the highest quality are also those who are providing the highest care at the lowest cost. Kind of almost counterintuitive, but it's true. Systems like Intermountain Health and Sutter, who are providing extraordinary service, extraordinary care to their patients, are doing so very efficiently. The folks at Virginia Mason outside Seattle, I know that's probably not a real nice place for you to think about. It's where Microsoft's located. Virginia Mason recently went to the insurer community and to Medicare and Medicaid and said, whoa. We have become so efficient at providing care that unless we change the dynamic, the transactional dynamic, how many times you see that patient, how many beds are filled, how many services are provided, we're doing a much better job at managing patients with fewer resources. We're going to market ourselves out of business. So it's a different dynamic. We advocate that you start thinking about incentivizing physicians and systems to start taking care of people based on outcomes as opposed to transactions. The more transactional services that we have, the larger costs are going to be. And guess what? We're an aging population. The boomers are expecting things immediately. And there's that expectation that if we don't change the dynamic, if we don't start focusing on prevention, if we don't start focusing on wellness, if we don't create those incentives, not only on the provider level, but bring those down to that individual patient, incentivizing folks to stay compliant with their medications, which we don't do. Focus on ideas that keep folks out of institutions. We've missed the boat.
What I was going to comment on, what we hear from physicians at the point of care where the rubber hits the road, and as Marie said, most of the ones that lag the furthest behind in adoption are small practices. These are doctors who are on a eat what you kill comp model. We don't have a healthcare system. We have a sick care system. They are actually incentivized. In some cases, if they misdiagnose, they actually get additional compensation to have the patient come back and have repeat tests and procedures. So until we align these IT incentives with helping doctors keep patients out of their exam rooms and out of the hospital, then I think that's where we'll see the critical mass adoption. But you gave e-prescribing as an example. It's a great tool. In fact, you can get money right now for it, and it's free. But what happens at the point of care is they introduce that tool into a workflow that all of a sudden fragments the paper chart, and their med list is now not reconciling with the med list in the ED or reconciling with their other partner who's not using e-prescribing. And as an unintentional consequence, they have now created a liability for themselves because they have now are storing drugs in a computerized handheld e-prescribing device. They have information in a paper chart. They probably have a log in the back. They probably have some dispensary unit that keeps track of certain things. And it potentially poses a threat to their productivity. And out of human nature, they tend to stop using it because it hurts their ability to maintain their incomes. That's the reality. I mean, I think that until we can crack that nut and figure out how to help doctors get paid for better quality, and that's largely what the outcomes is going to be. But give you an example. One thing that much of this talks about is using Medicare to drive this. Well, what if you're a pediatrician? What if you're a practice that doesn't have a lot of Medicare? What if you're in a certain market where that's just not your patient base? So a lot of that still has to be sorted out to get the critical mass that I think is going to be required.
Okay, go ahead, Marie.
Just to follow up on everything, I mean, I spend a lot of time working with these small physicians, and to talk about the e-prescribing, if you're a physician, you can do most of your stuff for e-prescribing. You can actually now do the mail order, folks. If any of you have chronic disease and do mail order, you cannot do controlled substances. So I've got this great electronic prescribing thing, but if I have anyone who's on any, controlled substance, I have to go to paper, or I have to make sure I have the special paper in my printer and print it out. Those are the kinds of things that we struggled with when I was at ACP, and it's not an easy thing. It's, as Jeffrey said, can I meet my payroll? And so, the upfront costs of providing an EHR, it's significant for these docs, and that's a group that we really need to take care of, because the majority of the care that Americans get are through these small practices. I think it's 50 or 60% of care comes through these small practices. So we need to find a way to help bridge that and get them going. The incentives, and there are incentives for Medicaid, in addition to Medicare, but the law is written that you can't get both. You've got to decide to be Medicaid incentives or Medicare incentives. And I think the bill tries to help in terms of access. I mean, fundamentally, they want to improve quality and improve access. And some of the systems, working with EHRs and coming to my company, what you want to do is save doctors time or money, because they're paid piecemeal. I mean, they are paid for how much they do on volume. So they want things that are going to automate. Every other industry has an automated tool. The whole idea of cutting and pasting and fraud, it was huge last year. I mean, it's an ongoing issue. And some of that is lobbying groups fighting against each other because everyone wants their piece of the pie. But when you think about all the requirements on a provider to document just to get paid, they can't meet their volume. I mean, physicians have to see, if you're in primary care, a minimum of 25 patients a day, and that's on top of everything else they have to do. So it's difficult to come up with solutions that help the workflow and not impede it. And I think that's what's happened a lot with the early adopters, especially when Jeffrey talks about 30% failure. They bit the bullet, said, yeah, I want to do this. It's supposed to help with quality, but it wasn't quite there yet. But things improve. The fact that we have standards organizations now and CCHIT to help make sure everyone's on a level playing field. I think the government realized that there were a lot of these folks who were getting a raw deal.
Well, and I just have to say, you have Stark laws, you have kickback. When you talk about incentives, you can't. That is a costly, and I hate the Stark law. I don't think anybody ever really understands it. It's very costly to try to figure out. So, that incentive to try to do it. And by the way, I travel a lot. I want an electronic record. But I also want to make a point about Medicare doesn't pay for wellness checks. They pay for one. So you want to talk about incentivizing people, and if you started paying primary care physicians for those sorts of checkups, that would probably help. The other issue is the quality question, which comes into situations where, what if the patient's in the hospital? What if the patient has a stay for cardiac arrhythmia? What if the physician performs a cath and wants to discharge, but the hospital says, wait a minute, you've got to bleed, and keeps the patient? Now, does that count as a quality tick against the hospital? Yeah, but not the physician. So, it's great to say, and I want quality care. I'm not totally averse, really, but I think there's a lot of it that you can't. It sounds great, and I think a lot of people are enthused, but when you get into some of the details, because we have such a regulated system, there are a lot of costs, and we're not paying for things like preventative care.
Just as a side note, the stimulus package impacts Medicare and Medicaid, and to think that that's the only care that's being provided out there is I don't want to say it's a little naive, but there's this whole other world out there of payers, and the road is beginning to be paved by Medicare and Medicare through the stimulus package and other incentives. But quite frankly, the private sector is also responding. Thank you very much. The large insurers are beginning to migrate there. They're not there totally yet, but they will develop because they're going to have to. Again, it's in their best interest to keep patients healthy. It's in their best interest to keep them out of facilities. It's in their best interest not to pay the large medical claims. So at some juncture, yes, the incentives are important, and yes, there are questions, and yes, there are some definitions that have yet to be decided and standards yet to be published. But all in all, it's a good start. At least it's some place where we can begin to plant the flag and say, from this point forward, quality is going to be important because we realize that quality will reduce costs. So.
Actually, that's a good dovetail because I want to bring it back to the stimulus for a second and talk about that. And Sean, I want to throw this to you first and let everybody chime in. But specifically talking about, well, one of the big focuses on the stimulus is recovery, but the idea is job creation is going to be a major component of that, obviously. So I think the administration has a plan for, I think, 1.5 million jobs over the next 3 years. I know a lot of the focus for the $20 billion for HIT in the package is aimed at or targeted to be a stimulus for job creation as a means to help the overall real economy. Just talk about that for a second, address that if you will, kind of where do jobs come in and what are some of the inter-industry dynamics of jobs in HIT and in the healthcare space?
Yeah, sure. Employment, a huge issue and factor in the stimulus programs. In fact, prior to the new administration coming in, that reached out to our organization and asked us some questions about what we thought the implications could be from stimulus programs in several areas that the government has made a significant commitment around. So energy, communications, and healthcare. And so together with other members of the industry, we formed and completed a study to say what kind of implications, job implications, could be created by investments, stimulus investments in the area of IT in each of these categories. And the work we did with outside parties to assess where those jobs could be created, how many, estimate of about 214,000 jobs could be created with a $10 billion investment in HIT. So that's a significant step in terms of job creation. And I think if you look at the numbers that we're seeing in this country, healthcare has been one of the bright spot areas. So in the last year and a half, we've lost 4.5 million jobs in this country. The most recent statistics from the month of February showed about another 500,000 jobs were lost. Healthcare created 30,000 jobs in the month of February. It's an area where there are unfilled jobs, so nurse positions. There are 100,000 open positions in nursing. Within the stimulus, there are specific investments that are being allocated towards the development of professional careers and capabilities in the areas of HIT. So there's a recognition that we don't have yet the capacity to deploy the programs that the government would like to see. We also recognize that there's not a competency to provide the kind of skills that are going to be important to be successful. And I think that's really interesting because when you think about the kind of jobs that we want to create high-value jobs, interesting, well-paying, from good employers that can help drive real opportunity for this country to move to another level. So there's very much an orientation towards how do we invest in the system to take us to a much better kind of system than just to fix or repair, patch roads, if you will.
Yeah, I was going to have Glenn follow up and Jeffrey as well.
I'm kind of rumbling over here. So.
Yeah. One of the things that we've heard, and there's kind of a group that voiced their concerns here on this topic specifically, is that there's an idea that the implementation of technology delivers certain efficiencies that, as a result, lead to some job cuts or elimination of needs in human capital. So there's a little bit of idea of it might be counterproductive a little bit in terms of specifically the idea of job creation. Can you speak to that?
Well, first of all, let me make an overall comment. I personally and GHA is completely committed to all this electronic moving forward. So anything I'm saying is more in the context of basically how we're going to pay for this stuff. And you're right, job creation is there, but my concern is that how are we going to pay for those positions? And what I'd like to do, just visualize a pie chart with me for a minute. This is based on 2006 discharges from Georgia hospitals. This is real data, absolute facts here. 20% of Georgia's inpatients are Medicare. Medicare, on average, pays Georgia hospitals about 96% of what they spend. 4% loss. Okay, 20% of your pie chart, 4% loss. Next segment, 20% is Medicaid. Medicaid pays on average 84% of what it costs. Okay? Next segment, 17%, no insurance. Okay? You collect about 5 to 10% of cost from the uninsured. So look at your pie chart. 57% is red. And a lot of it's deep red, like the uninsured. 17% pay basically nothing.